Hi, this is Kumar Madassery. So the question I was asked here is, how do I maximize IVL treatment in the peripheries? I think it's interesting because I think everyone has different practice patterns, but a lot of us who do this PAD and CLTI work specifically kind of tend to seem to follow a lot of similar patterns. I think it depends on if we're talking about a CTO or we're talking about heavy stenosis with calcium, and where our wire and pathways are and what we're connecting to what, and what level of the peripheral arteries we're treating. For me personally, I think it's a matter about knowing where my wire is within a lumen and understanding how much calcium am I dealing with. You can often tell that from a CTA, from your fluoroscopic images, and especially the IVUS is a great way to know where the calcium is. Is it circumferential? Is it chunky? Is it just eccentric? What is it? Because all of those have different ways to kind of tackle it, or sometimes you have some limitations in how you tackle it. But for me, I think it's important to confirm that I do have a lot of calcium, which you often know very easily. And then it's about sizing it and understanding how to get the pressure up on the balloon to the caliber of the vessel that you want to get. And if I deliver the pulse therapy based on the size and along the segments that I want to treat, and I get it to the caliber, I'll do an angiogram afterwards, and also if needed for education and for confirmation, you can run IVUS to really see, has the vessel really gotten expansion? Do I like it? Am I not dealing with much dissection, or in the rare circumstance, perforation, which is not that common, especially when you use IVL? Then I'll decide to use my drug-coated balloon, or depending on what segment I'm on, a plain balloon or a scaffold if I feel it's necessary if there is a dissection. Sometimes you can't avoid it no matter what you do, but you may be able to limit the lengths of it and the complexity of it. Quite often I find when I treat a segment with IVL, then I don't need a scaffold. But some areas, there's nothing you can do about it. Eccentric calcium is one of the biggest problems we still have, and sometimes you have to use IVL plus adjunctive other specialty tools. So those are all things to kind of decide how to treat in the periphery. I think it's more about getting the maximum size you can out of your vessel with the balloon, and IVUS helps with that, to know what is your nominal diameter of that vessel, to start, and then you size it and you try to get that caliber, and delivering the treatment as much as necessary to get that balloon expanded to the vessel walls, and then using your adjunctive techniques at lower pressure, especially plain balloon. It's nice that you don't have to necessarily use high pressure balloons or specialty balloons like scoring, cutting balloons, or anything like that quite often when you do it this way. So I think maximizing it is about knowing that you have circumferential calcium, knowing that you sized it well, whether it's tibial, fempop, or even iliac, and then being able to get that wall-up position with low pressure with your subsequent treatments is the best way to maximize it. And checking with IVUS and your angiograms really help you confirm that you're getting a good outcome at the end of the treatment.